Well, welcome everybody. I can see people are starting to get their way in here. So I think I'm going to go ahead and get us kicked off. I'm Bianca Frogner. I am the chair of our webinar committee here for the Award Network. We have a packed group of speakers today, which is fantastic. And so I want to make sure that people have the most amount of time possible to really give their talk today. So I'll go ahead and start off with some house cleaning. Again, my name is Bianca Frogner. I'm a professor at University of Washington, directing the Center for Health Workforce Studies. I'm part of the Award Network Leadership team, as well as being the chair of our webinar committee. I'm excited to have this fantastic talk today on guiding an improved dementia experience, or the GUIDE model, and implications for the dementia care workforce, being the topic for today. We will have Emily Franzosa, one of our webinar committee members, introduce everybody. So we'll come back to that. And if you want to kind of keep up to date on future webinars, please do check out our website. We would also love to hear any ideas you might have for future webinar ideas. And you can scan the QR code at the bottom. And with that said, the next one that is coming up will be in January. Nathaniel Chin from Wisconsin's Alzheimer's Disease Research Center, as well as the Wisconsin Registry for Alzheimer's Prevention Study. We'll be talking about how some of the new novel therapies are, as they come on board, what that means for the clinical workforce. I do want to note that the webinar is the second Wednesday, not the first Wednesday of January, as we typically do, because it's right after New Year's otherwise. So we want to give people a chance to ease back into the new year before we start off our next webinar. So I want to thank, again, the webinar committee for the Award Network, who have been tirelessly working to make these webinars come to life. So thank you very much to all of them. And a couple other announcements about that, just other activities are happening in the Award Network in case you missed it in your emails. And of course, you can always sign up for newsletters via the website. There is a new research internship award coming. Actually, it might even be live at this point in time. Applications are due February 28th, and you can ask for up to $5,000 in costs as part of this internship. And we have a summer institute that's coming up next July. And again, details are starting to emerge and show up on the website. So please mark your calendars for that. And we are excited to see some of you in person and spend some time with you next summer in San Francisco. So again, please check out our website. That's where you can find the latest, greatest information about what's happening in the Award Network, as well as you can sign up for newsletters to keep abreast on what's happening. And I just want to acknowledge that National Institute on Aging is the supporter behind the Award Network, and without them, we would not be able to do what we do here today. So with that, I'm going to ask Emily to go ahead and turn on her camera and join us here as we kick off the session.
Great, thank you so much, Bianca, and welcome everyone. We're so delighted today to have this fantastic team from the Center for Medicare and Medicaid Innovation with us to talk about the development of the GUIDE model, which is a new, very exciting and innovative way to think about structure and pay for dementia care, and I think has a lot of relevance to the dementia care workforce and the way that we think about the folks who are providing this care, and the research and practice that we're doing as well. So we are lucky to have a deep bench today of folks who are going to talk about this. We've distributed their full bios to you already, so I'm not going to take too much time with introducing folks, but do just want to mention them briefly. So first we have Tanya Saffer, who's the director of the Division of Healthcare Payment Models within the Patient Care Models Group at CMMI. And she leads the team of researchers and technical experts who are working on healthcare delivery and payment innovations to help Medicare and Medicaid beneficiaries with serious illness remain independent and stay in their homes and communities. Also on the team, we have Sage Hart, who's a health insurance specialist for the Division of Healthcare Payment Models within CMMI. Prior to joining CMMI, Sage worked for 10 years as an attorney in private practice focusing on elder law and special needs planning. Next, we have Serena Ho, who's a health insurance specialist at CMMI and a member of the Guide Model team, and leads the quality, health equity, and stakeholder engagement work streams. And then finally, we have Lynn Misher, who works as a social scientist with CMMI, evaluating new payment and care delivery models for people with serious illness. So we're really lucky to have panelists who can speak to so many different angles and perspectives on this model. So the CMMI team is going to talk to us for about 30 minutes, and then we're going to hear from Dr. Rastana Kaufman, who is a health services researcher focused on improving the value of care for older adults, particularly those with multiple chronic conditions. And Dr. Kaufman will offer some additional remarks. And then we're going to leave about 10 minutes or so at the end to make sure that you're able to ask any questions of the team that you want. Feel free to put those in the Q&A along the way, and we'll review them at the end. But with that, I'm going to turn it over to our team. So Tanya, do you want to get us started?
Yes, thank you for that great introduction. And thank you to the Award Network for inviting us and hosting us here today. We're really excited to share the work that the Innovation Center has been doing, and this many members of this team have been working on over the past several months, quite over a year. So happy to join you here. I am Tanya Saffer. I am the Director of the Division of Healthcare Payment Models at the Innovation Center. And as Emily said, our division leads work in caring for people with serious illness, including the Guide model. And we're just so pleased to share that model with you today and have a great discussion. So briefly, we'll run through the agenda on the next slide. And we've done our introduction, so the model team will review some background information on the Guide model before diving into the bulk of the presentation, which is where they will share an overview of the Guide model policies, including information on payment methodology, care delivery requirements, quality measures, health equity policies, as well as the model evaluation process. Next slide, please. These are the team of brilliant colleagues that I have here today, experts in research, policy analysts, and legal experts who have been working on the model, and they'll join just shortly. And on the next slide, we'll present this opportunity and we'll dive in to support practitioners in delivering and testing the impact that a comprehensive dementia care program can have on the lives of people living with dementia and their caregivers. And as I said, we look forward to a robust discussion. I'm also privileged to share the stage with Rastana Kaufman, who spent some time in our division as a health and aging policy fellow, working to shape the Innovation Center's thinking around serious illness care. So happy that she's joining us after the presentation here. For now, I'll turn it over to Sage Hart to dive right in. Next slide, please.
Great. Thank you, Tanya. And hello, everyone. I appreciate you joining us for today's event. During this section of the webinar, I will walk us through a bit of background information related to the Guide model. Dementia is a major public health issue and is increasingly affecting the American population. About 6.7 million Americans currently live with Alzheimer's disease or another form of dementia, a number that's projected to grow by nearly 14 million by 2060. Many people with dementia are not consistently receiving high-quality, high-value care. Some of these issues include a lack of caregiver training and recognition, unestablished healthcare pathways, limited coverage of key supportive services, and a lack of sustainable payment for comprehensive care. The Guide model aims to address the existing gaps within our nation's current dementia care landscape by testing if a comprehensive package of care coordination and management, caregiver support and education, and respite services will improve quality of life for people with dementia and their caregivers, while delaying avoidable long-term nursing home placement and enabling more beneficiaries to remain at home through end of life. Next slide, please. The Guide is an 8-year voluntary model offered in all states, DC, and US territories. The Guide model, the model performance period will begin on July 1st, 2024 and end on June 30th, 2032. The Guide model will have 2 participant tracks, one for established dementia care programs and one for new dementia care programs. And we will talk more about track selection for model participants later in today's presentation. The application period for both participant tracks opened on November 15th, 2023, and will close on January 30th, 2024. The first performance year for the established program track will begin on July 1st, 2024. And the new program track will have a 1-year pre-implementation period that begins on July 1st, 2024. And its first performance year will begin on July 1st, 2025. Next slide, please. I will now cover the participant eligibility requirements. Next slide, please. GUIDE is designed to attract a range of Medicare Part B enrolled providers and practitioners with the expertise and capabilities to establish a dementia care program and provide ongoing care and support to people with dementia. Examples of eligible participants include a standalone physician practice, practices that are part of a health system or ACO, and practices that have established by a hospice agency, home health agency, or PACE organization, but operate as a separate Medicare Part B enrolled service line that bills under the Medicare physician fee schedule. During the model, GUIDE model participants must meet the care delivery requirements as described in the care delivery section of the IRFA, but they may choose to partner with other organizations, including Medicare enrolled providers and suppliers and non-Medicare enrolled entities, such as community-based organizations, to meet these requirements. Next slide, please. GUIDE participants must meet the following requirements, among others specified in the participation agreement throughout the performance period of their assigned track. That is, the participant must meet the interdisciplinary care team, care delivery, and training requirements as outlined in the care delivery section in Appendix B of the RFA. They must also use an electronic health record platform that meets CMS and the Office of National Coordinator of Health Information Technology standards for certified electronic health record technology. The GUIDE participant has the flexibility to provide most model services virtually or in person, and that is either in the office or in the beneficiary's home, but they must conduct an initial home visit in person for aligned beneficiaries who have moderate to severe dementia. The GUIDE participant is required to make available for eligible beneficiaries GUIDE respite services in the beneficiary's home. The GUIDE participant has the option, but is not required to offer eligible beneficiaries GUIDE respite services in an adult day center or a facility that can provide 24-hour care. More details regarding GUIDE respite services can be found in the respite payment section of the RFA. The participant must maintain an up-to-date GUIDE practitioner roster and partner organization roster if applicable, as we'll discuss in more detail soon. And lastly, they must comply with all model reporting requirements, including care delivery, sociodemographic data, and quality reporting. Next slide, please. As briefly mentioned earlier in our presentation, the GUIDE model will have 2 participant tracks. To support the development of new dementia care programs, GUIDE will have a track for established programs that will launch on July 1st, 2024, and a second track for new programs that will include a 1-year pre-implementation period, and they will start the performance period on July 1st, 2025. To be eligible as an established program track participant, the organization must already provide comprehensive dementia care and be ready to immediately implement GUIDE's care delivery requirements. For the new program track, GUIDE will recruit and support model participation for organizations that do not currently offer comprehensive dementia care or have prior experience with alternative payment models. And through this, the GUIDE model aims to improve access to comprehensive dementia care nationally. Next slide, please. Participants must maintain an interdisciplinary care team, as I mentioned, and at a minimum, the care team must include a care navigator and a clinician with dementia proficiency who's eligible to bill Medicare Part B evaluation and management services. At the participant's discretion, the care team may also include additional members, such as a pharmacist, social worker, and behavioral health specialist. A clinician will qualify as having dementia proficiency if they can meet at least one of the following criteria. And that is, first, attest to having at least 25% of their patient panel, regardless of payer, at some time in the past 5 years, comprised of adults with any cognitive impairment, including dementia. Or second, attest to having at least 25% of their patient panel, regardless of payer, at some time in the past 5 years comprised of adults aged 65 years old or older. Or they may have a specialty designation of neurology, psychiatry, geriatrics, geriatric psychiatry, behavioral neurology, or geriatric neurology. Next slide, please. The guide participant will be required to maintain and keep updated throughout the course of the model a guide practitioner roster, and if applicable to their program, a partner organization roster. The guide practitioner roster is a list of physicians and non-physician practitioners that will be providing services under the model. This list must include at least a clinician with dementia proficiency. The guide practitioner roster will be used to determine who is eligible to bill for guide model payments. So, for example, the guide participant will be identified by a single TIN that's used to bill for guide model services, plus the national provider identifiers of the individual Medicare enrolled physicians and other non-physician practitioners who have reassigned their billing rights to the guide participant's billing TIN and are listed in the guide practitioner roster. If a guide participant contracts with either Medicare enrolled or non-Medicare enrolled entities to meet the care delivery requirements of the model, these contracted providers and suppliers will be known as partner organizations and must be reported on a partner organization roster. Next slide, please. The primary beneficiary population for the guide model are community-dwelling Medicare fee-for-service beneficiaries, including beneficiaries duly eligible for Medicare and Medicaid, who often experience fragmented and uncoordinated care. The eligibility requirements for beneficiaries are outlined on the left-hand side of the slide, and they include that guide beneficiaries must have dementia, as confirmed by attestation from a clinician practicing within the guide dementia care program. Beneficiaries must be enrolled in Medicare Parts A and B as their primary payer, and not in Medicare Advantage, including special needs plans. And they also must not be enrolled in the Medicare Hospice Benefit, or a PACE program, as these services overlap with those provided under the guide model. The guide model will use a voluntary alignment process for aligning beneficiaries to model participants. And this means that participants must inform beneficiaries about the model and the services that the beneficiaries can receive through the model. And the participant must document that a beneficiary or the legal representative, if applicable, consents to receiving services from the participant. Participants will submit documentation to CMS, and CMS will confirm that the beneficiary meets the model eligibility requirements before aligning the beneficiary to the participant. And even after a beneficiary has opted in and been aligned to a model participant, beneficiaries will maintain their complete freedom of choice in where to seek care. I will turn it over now to my colleague Serena for the payment methodology slides.
Awesome. Thank you, Sage. All right, so I will now talk about our payment methodology. So the primary payment under guide is a per beneficiary per month care management payment called the Dementia Care Management Payment, or the DCMP. And the DCMP will replace billing for a small set of existing physician fee schedule services. And the DCMP is designed to give participants more flexibility to deliver personalized dementia care than is possible under a traditional fee-for-service. It covers a more comprehensive set of services than existing care management codes. They're less burdensome to bill, and they allow for reimbursement for members of the interdisciplinary care team who are otherwise not eligible to bill for Medicare services. The DCMP will also not be subject to beneficiary cost sharing, and the model is not a total cost of care model, so all services that are not included under the DCMP may continue to be billed under traditional fee-for-service. The DCMP will have 2 monthly adjustments, a performance-based adjustment, which can either increase or decrease the DCMP, depending on how well a participant performs on the model's performance metrics, and a health equity adjustment that is based on beneficiary level health equity factors and may also increase or decrease payment. And we'll discuss both of these in more detail later. In addition to the DCMP and its adjustments, participants will be able to bill for respite services that are provided to certain eligible beneficiaries, up to an annual cap of $2,500 per beneficiary per year. Beneficiaries with a caregiver and moderate to severe dementia will be eligible for these services. Participants will be able to bill for respite services provided in a beneficiary's home, in an adult day center or in a 24-hour facility. The performance-based adjustment will be calculated annually and applied monthly to the participant's DCMP, and it can either decrease or increase the monthly payment depending on the participant's performance on the 5 guide quality metrics. Each metric, which they're listed on the slide here, each has an associated PBA potential, which can be seen in the table here. And once all 5 of the measures are phased in, a participant's total PBA potential can range from -3.5% to 10%. The timeline on the slide here indicates when each PBA will be applied for each program track. And since the PBA is based on participant performance and quality data, and that'll be reported annually, the first PBA will not be applied until each track's second performance year. The DCMP rates here represent the base payment rates, and they'll be adjusted for geographic variation in costs as well as cost growth over time. To account for geographic variation, CMS will be adjusting DCMP base rates by the Medicare Geographic Adjustment Factor, or the GAF, for each DCMP claim submitted by a guide participant. The GAF is applied to the DCMP in a weighted geographic adjustment based on all services in the Medicare physician fee schedule. To account for cost growth over time, CMS will annually update the DCMP base rates by the Medicare Economic Index, which is a measure of physician practice cost growth calculated by the CMS Office of the Actuary. Here are some participant payment examples. So the first 2 examples below show how total guide model payments will be calculated for an individual aligned beneficiary over the course of a full performance year. So in the first example here, the beneficiary is in a tier that is eligible for guide respite services. And that example assumes that they reach the respite cap for the year. And in the second example, the beneficiary is in a tier that is not eligible for guide respite services. And both of these examples are rounded to the nearest dollar and assume that all beneficiaries are newly aligned in the first month of the performance year and therefore are eligible for the new patient DCMP rate for the first 6 months, and then the established patient DCMP rate for the next 6 months. I will now pass it back to Sage to walk through the care delivery requirements.
Thanks, Serena. And in the next section of today's webinar, as Serena just mentioned, I will cover the care delivery requirements of the model. As mentioned earlier, there's a standard minimum set of care delivery services that participants must provide as part of the model. And participants must be able to provide the services at varying levels of intensity, depending on the beneficiary's model tier and their individual needs. The care team will deliver services by creating and maintaining a person-centered care plan, which will include details on the beneficiary's goals, strengths, and needs. The graphic on this slide summarizes these services and includes the 9 care delivery domains as outlined in the sections on the slide. And the guide model participant has the option to contract with a partner organization to make certain services available to their beneficiaries, including 24/7 access to a member of the care team or helpline, referral and support coordination, respite services if needed, and the caregiver education and support. Next slide, please. As part of the comprehensive assessment, the guide participant will administer approved screening tools and submit the resulting scoring data to CMS on the patient assessment and alignment form. CMS will use this data to assign beneficiaries to model tier for payment. The table on this slide shows how the screening tool scoring corresponds to the guide model tiers. CMS guide model participants must use a tool from a set of approved screening tools, dementia stage and caregiver burden. The approved management tool set includes 2 tools to report dementia stage. That's the clinical dementia rating, or CDR, and the functional assessment screening tool, or FAST. And there's 1 tool to report caregiver strain, the Zaret burden interview, or ZBI. Alternatively, the guide participant will have the option to seek CMS approval to use an alternative tool by submitting the proposed tool along with the published evidence and crosswalk for how it corresponds to the guide model's tiering thresholds. And now I'm going to pass it back to Serena to talk about the guide quality strategy.
Thanks, Sage. So in the next section of the webinar, I'll walk through some of the quality measures and the reporting criteria for the guide model. So CMS plans to measure guide participant performance on 5 measures, including quality, patient experience, utilization, and cost metrics. So the measures that are included in the guide model set are use of high-risk medications in older adults, quality of life outcome for people with neurological conditions, a caregiver burden measure, total per capita cost, and the long-term nursing home stay rate. The caregiver burden and long-term nursing home stay rates are new metrics that will be developed for use in the guide model specifically. And these 5 measures in the performance set will be used to adjust the guide participants' monthly DCMP, and we'll plan to phase in the use of these measures over time. So as mentioned earlier, guide participants will complete care delivery reporting at least once per year, which will consist of a series of questions about how they're implementing the care delivery requirements of the guide model, including how frequently they're interacting with aligned beneficiaries and their caregivers and what care modalities they're using. CMS will require all guide participants to collect and report certain beneficiary level sociodemographic data and health related social needs data from aligned beneficiaries who are willing to share this information with the participant. And participants are not required to report data to CMS for any beneficiary who chooses not to disclose these data. Guide participants will be encouraged to use one of 2 preferred HRSN screening tools, which are the Accountable Health Communities or AHC screening tool, or the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences, or PREPARE tool. The guide participant will be required to annually report HRSN data that's aggregated across aligned beneficiaries and includes domains such as food insecurity, housing instability, and transportation needs. This expanded data collection and guide will help allow CMS and guide participants to evaluate their beneficiary demographics and inequities and disparities among the communities they're serving. CMS will allow organizations to participate in both the guide model and in all other current Innovation Center models for which they meet the eligibility criteria, as well as the Medicare Shared Savings Program. So CMS will allow participant overlap at the TIN and NPI level with the ACO REACH model, the Shared Savings Program, and the 3 comprehensive kidney care contracting options in the Kidney Care Choices model. Eligible beneficiaries may simultaneously be aligned to the guide model and attributed to participants in any of these models. So eligible beneficiaries may simultaneously be aligned to a guide model participant and a participant in the BPCI Advanced and CJR models as well. The DCMP includes care coordination services similar to other Innovation Center models, such as Primary Care First, Making Care Primary, the Maryland Primary Care Program, the Enhancing Oncology Care model, and Kidney Care First, and guide will permit participant overlap at the TIN and NPI levels with these models as well. I'll now talk about the different components of Guide's health equity strategy. So at a high level, in CMMI's most recent strategy refresh, the center outlined our top 5 priorities, and one of those pillars is advancing health equity, and more specifically, embedding health equity in every aspect of CMS Innovation Center models and increasing focus on underserved populations. And really, CMMI aims to measure progress towards this goal in 3 main ways. So first, all new models will require participants to collect and report demographic data of their beneficiaries and, as appropriate, data on social needs and social determinants of health. The second is all new models will include patients from historically underserved populations and safety net providers, such as community health centers and disproportionate share hospitals. And third is CMMI is encouraging us to identify areas for reducing inequities at the population level, such as avoidable admissions, and to set targets for reducing these inequities. And this advanced health equity pillar is really one that every model is seeking to embody through model development and deployment. And we'll talk about what that looks like for Guide specifically on the next slides. So in GUIDE specifically, our health equity strategy contains several components, and this was informed not only by research into best practices and center-wide guidance, but also through listening sessions with interested partner groups, as well as conversations we've had with beneficiaries and caregivers. And as part of the presentation today, I'm going to highlight 4 of the key components of GUIDE's health equity strategy, which are the health equity adjustment, the infrastructure payment, the health equity plans, and expanded data collection. So the GUIDE health equity adjustment will be calculated annually and applied monthly to GUIDE's DCMP payment, and each beneficiary will receive an equity score based on social risk factors, which are National Area Deprivation Index, State Area Deprivation Index, low-income subsidy status, and dual eligibility status. The equity score will be calculated according to the equation on the slide here. And we arrived at this formula because in the case of a maximum score, the national ADI is worth 25% of the score, the state level ADI is worth 25%, and low-income subsidy status or dual eligibility is worth 50%. And this aligns with the approach that's been taken in some other CMMI models and really balances area level factors with beneficiary level characteristics. Based on each equity score, for beneficiaries with scores above the 80th percentile, a positive $15 adjustment will be added to the DCMP. The bottom 50% will have a negative $6 adjustment, and the remainder will be neutral. The next component I'm going to talk about is the infrastructure payment, and the infrastructure payment will be available for new program track participants who qualify as GUIDE safety net providers. And I'll talk about the qualification process in a minute, but in a nutshell, it is a one-time $75,000 payment that will be geographically adjusted, and it'll be awarded at the beginning of the pre-implementation period, and really is designed to assist GUIDE safety net providers with building their programs. And participants will qualify if they serve a Medicare fee-for-service population of at least 36% receiving the Part D low-income subsidy, or 33.7% who are duly eligible. And these thresholds are CMMI level definitions that have been established to help the center track and promote safety net provider participation among models. CMMI will also require participants to submit health equity plans annually, which will help participants identify, measure, and reduce disparities in outcomes within their patient populations. So as part of the baseline care delivery reporting survey, participants will submit an initial health equity plan focused on beneficiary outreach and engagement, with the goal of implementing equitable recruitment strategies to reach historically underserved groups. The annual health equity plans will be part of the annual care delivery reporting, which focuses on reducing disparities in dementia care through implementing initiatives to measure and reduce disparities, including helping participants goal set and report progress towards their goals. This is the last section I'll talk about for health equity, and I spoke a little bit about it earlier, but as you know, we'll be collecting a variety of data from our participants. The first being sociodemographic data, and participants will be required to report this core set of measures for each beneficiary. And the second element is health-related social needs, and HRSN screening and referrals are part of the model's care delivery requirements. So participants will be required to screen for HRSNs as part of the comprehensive assessment and refer beneficiaries to appropriate supports if they screen positive. With that, I will pass it to Lynn to talk about the GUIDE model evaluation.
Thank you, Serena. Today, I'll describe the purpose of the GUIDE model evaluation and our overall approach. Next slide, please. All Innovation Center models require an independent federally funded evaluation. By statute, the evaluation will inform any decision by the Secretary of HHS to expand through rulemaking the duration and scope of the model. GUIDE model participants must cooperate with the evaluation as a condition of participation. Participant activities typically include surveys, interviews, and site visits, and other activities such as data submission necessary to conduct a comprehensive evaluation. Next slide, please. The purpose of the guide evaluation is to assess model implementation, the experience of participants and beneficiaries over time, and effects on model outcomes related to the 3 primary guide model objectives. Guide is largely focused on quality of life and caregiver burden, as well as helping people remain in their homes and communities while reducing Medicare and Medicare expenditures. Model participants will be asked to submit quality of life and caregiver burden data to CMS. For the evaluation, similar quality data will need to be collected directly from a comparison group comprised of providers not participating in the model. Next slide, please. A mixed methods approach will be deployed to evaluate the model using both quantitative and qualitative data to produce valid impact estimates usable for model expansion decisions based on cost or quality. The comparison group will be identified among providers as similar as possible to model participants. Our ability to estimate effects depends on adequate participation in the model and beneficiary recruitment and submission of sufficient quality of life and caregiver burden data to CMS. Potential effects include improvements in quality of life and caregiver burden, reductions in long-term nursing home stays and Medicare and Medicaid expenditures, better experience of care for beneficiaries, caregivers, and providers, and overall transformation in the delivery of care for people with dementia. Now I'll pass the mic back to Sage to close out the presentation.
Thanks, Lynn, Tanya, and Serena. I know we'll have time for some questions at the end of today's session, but first I would like to pass it over to Prasanna for her remarks.
Kristen, I think you're on mute.
Sorry about that. So I am Prasanna. Thanks everyone for the presentation and all the information about the guide model. As a health and aging policy fellow, I got to work with Tanya and her team as they were developing the guide model, and it was really an incredible experience to see how much thought and evidence and stakeholder engagement went into developing this model. I do have a few slides that I am trying to share, and it doesn't want to let me share. But I will add that my role in September ended there in September, and so these comments are my own and do not reflect the Innovation Center or by other employers. And then being a part of that team and learning about the guide model, I was really interested in focusing on opportunities for serious illness care. Thank you, Emily, for sharing the slides. I'm not sure what happened. It worked earlier. And so the opportunities for serious illness care, as Tanya mentioned, the guide model starts at diagnosis, and there are various tiers that beneficiaries progress over the course of their illness. So at the higher end of those tiers, we're providing this holistic care for people with serious illness. And so I'll highlight some of the points that were raised by the CMS team today, and also potential implications for workforce as this model is implemented. Yes, thank you, Emily. I'm seeing those slides now. So the guide model definitely builds on other models and things that have worked well. For example, in ACO REACH, leveraging the health equity adjustment and health equity plans. It also draws on other models like the oncology care model and the care navigation, the focus on care coordination and navigation. But I'd like to highlight some of the ways that the guide model is breaking new ground. For example, these new quality measures and the goals of the model really focusing on quality of life, and not just for the beneficiary, also for their caregivers. In addition to the goals being innovative, the care delivery model is the first model to provide standards for holistic care and tie payment to social factors as well as clinical need. as they talked about with the health equity adjustments and in the care model requiring care navigation that also connects to social services in addition to clinical services. So as a palliative care researcher, I was really excited to see that these principles of palliative care and whole person care were really thoughtfully integrated into this new model for dementia care. And in that process of integration, setting some baseline standards for what would be expected to provide high quality care to seriously ill beneficiaries. So hopefully we'll see this continue in other models, and I think a lot of that will depend on how good the guide model is implemented here. So just a couple of ideas today about how these novel aspects might impact the workforce. So if we go to the next slide. And the goals for care. They mentioned that there are two new measures, one of those being the caregiver burden. And so the one on long-term nursing home stay, we've seen similar measures used in managed care or Medicaid managed care models, but the caregiver burden is really novel. So it'll be interesting to see how the development of that model and that quality measure and the implementation motivate additional supports and training for caregivers, which are required as a part of the care delivery model. Also, in the goals for quality, the guide model requires a health equity plan to reduce disparities and focusing on outreach to engage underserved populations. So I'm wondering, if having these health equity plans and focusing on outreach might impact the diversity of the healthcare workforce. So hiring care navigators or nurses who reflect the population that's being served is one evidence-based strategy that providers might implement that could shift the workforce that we currently have. On the other hand, models like ACO REACH have similar requirements. We don't really know what those impacts have been. So it'll be interesting to see if the guide model is setting those right conditions, setting the right incentives to improve disparities, while still allowing some flexibility in how providers achieve that goal. So the next slide. Again, showing how the guide model components really align with these principles for high quality serious illness care. And that really means going beyond the clinical diagnosis and addressing those holistic needs for the person as well as their caregiver. So the focus is really around care navigation, and so the interdisciplinary care team requires that dementia specialist as well as a care navigator. And so some of the people who might serve in that role might be registered nurses, licensed clinical social workers, as well as community health workers. So that's a pretty broad range. And we don't know yet how provider groups participants will implement their care model and which workforce elements will be most impacted. We do know that there will be required training for these individuals that will focus on specific topics, including advanced care planning, and that they will be expected to coordinate across Medicare and Medicaid services for people who are dual eligible and enrolled in Medicaid as well as Medicare. So that's an extra layer of care coordination. So the impact that we might see on impacting Medicaid services is a really important component of the evaluation of this model, like Lynn mentioned. And the health equity adjustment in the payments might also compensate for this extra layer of care coordination for duals. Second way that we might see this care model impact the workforce is through the unpaid caregivers. And so that's another role that is so important in addressing care for this population, obviously. And the more that we can provide support for unpaid caregivers, the better that they will be able to do their job and also take care of their own needs. So at a minimum, providing caregiver skills training, diagnosis information, support service, and then of course, paid respite care. So caregivers can have a break to focus on what they need to do in their own lives. So like the CMS team mentioned, those respite care dollars can be spent for in-home care or facility-based care. So again, it really depends on the implementation and how beneficiaries and provider participants use that benefit. You know, if it is used primarily for in-home support services, we could see, you know, that additional revenue supporting the workforce for home-based care and in-home care. Next slide. And on the payment side, you know, they mentioned that this replaces some payment for existing fee for service payments. For example, chronic care management, the new principal illness management, transitional care management, advanced care planning, all of those are kind of bundled together in this per member per month payment. And there's also the health equity adjustment for people who are dual eligible and low income. There's additional funding to support that coordination with Medicaid services. So that has been a real gap in that coordination across Medicare and Medicaid, or Medicare and social services and community-based organizations. And so hopefully this additional incentive and payment will better support and build that infrastructure that we need to connect people with the services they need. And I'll wrap up so we have some time for questions, but let's go to the next slide and I'll just touch on these really quickly. You know, the tiers that they talked about will evolve over time and hopefully allow for seamless transitions as people progress through their illness. But there also might be some intended consequences to think about. This is the first model I'm aware of that has changed payment for people with caregivers versus without. And so I'm curious, you know, how that might encourage people to document caregiver data, which would be a really good thing. On the other hand, there's higher payment for people without caregivers. And that additional payment for people without caregivers is intended to support additional services use. On the other hand, if there is an unpaid caregiver and providers get paid less while also becoming accountable for the caregiver burden and caregiver training, I think this raises some questions, and we need to watch to see how this model impacts the documentation of caregivers and recognizing caregivers in our electronic health systems. And the last point I want to make is just to highlight the importance of the Medicaid services and the evaluation of this model. We could certainly expect to hope to see decreases in Medicaid skilled nursing and nursing home spending due to delayed nursing home admissions. But we might also see increases in Medicaid services in the community due to that better coordination of services and improving access by helping people navigate to access the services that they need. So we've seen that in North Carolina with our special needs plans, shifting some of the resource use into the community. So that would be another thing to pay attention to, which is great because we are supporting people in the community, we're improving and supporting the workforce for home-based care, but that might impact the cost as well. So thank you all. This is really excited to hear the discussion and see some questions today. And personally, I'll be watching to see the impact on the palliative care workforce and how the participants in the model are engaging and working with providers who are experienced in serious illness care. And then, you know, whether we see these principles extended into other models for serious illness care. So I'll turn it back to you, Emily. Thanks so much.
Thank you, Bristana. That was really wonderful and some very thoughtful comments on this. And I'd like to invite all our panelists to come back on camera for our last 10 minutes. And for folks to please go ahead and put any questions that you have into the chat. Thank you all. This was just so informative, and it's just so clear all the work and thought that's gone into this model. So thank you for that as well. And I would actually like to start off with a question. I'll take moderator's privilege. I think one of the really exciting things about this model is the way that it really focuses on the interdisciplinary team and the importance of providing that coordinated care. And I think it's also very exciting just to look at, the amount of data that you're planning to collect, as well as this really comprehensive evaluation piece. So our group is mainly researchers looking at the dementia care workforce. So I'm wondering if you could speak to how researchers can be helpful to CMMI in helping to implement and evaluate guide, in addition to the work that you are already doing internally. And what kind of important workforce questions might we be asking? What would be helpful?
I think those are really great questions. I think multiple people on the team might have some thoughts, but I thought I would start with Lynn. Lynn, just framing that question, we do our own independent, we have our own independent evaluation for the guide model, but what have you seen other researchers do to kind of support evaluation and evidence for other models that they might want to do for this model as well?
So we do hire an independent evaluation contractor, and through the contract vehicle, we have in the past had researchers subcontract through the prime contractor, and those decisions are made, through the solicitation and through the independent contractor vehicle. So that's one mechanism. But I think overall, to support the model development and to look at and to develop research questions that we're focused on in the evaluation, we've delved into the literature. And so really value the articles that are being published currently in this space and bringing that to our attention, to help inform what we end up finding and interpret what we end up finding in the model evaluation.
Other thoughts from the team on the workforce component? Interesting, and whether something to look into. I think, as Bristana mentioned, she hit it, was just there's sort of a broad range of interdisciplinary care team members that could be participating in this model. And I think each program might look a little different. I will say that we have a requirement to, while different health professionals could be care navigators in this model, including community health workers, we are requiring that those care navigators receive comprehensive training across 13 domains that include person-centered care planning, common behavioral symptoms and management strategies, functional needs, safety, and how to support caregivers, among several other categories. I think that's, an area of interest to see how those care navigators and that training that they are going to need to receive is effective in supporting beneficiaries and caregivers, and how beneficiaries and caregivers receive and sort of respond to that support.
Wonderful. Thank you. So we have a question from Scott, who wants to know, Serena mentioned that all services not covered by DCMP will still be billable. Are there important nuances with this if care is still directed at dementia diagnosis?
Yeah, that's a good question. So that's right. Since the model is not a total cost of care model, all services that are not covered under the DCMP will continue to be billed under traditional fee-for-service. And on our model website, we have our request for applications, which includes the full list of codes that are covered or are able to be replaced by the DCMP and which are not. So that will be a helpful reference point for sort of understanding what other or what services are and are not covered.
Okay, wonderful.
And I would say Just to clarify and add to that, it'll be so if it's not on that list, it's separately billable. So you'll find that list in the RFA and in the FAQs. And high score.
Great, and we can share that link and that information with folks on the webinar with our group as well. We also have a question from Lauren who says she's wondering about unintended consequences of excluding hospice enrollees, and that guide patients might have delays accessing hospice care. Are there thoughts about how to mitigate that unintended consequence, perhaps by having a lower tier for hospice enrollees in the future?
Sage, do you want to take that one?
Sure. We do, and we have actually discussed this topic before, and are going to watch and think about ways to possibly mitigate any consequences if there are any. We do recognize in providing this type of collaborative care and encouraging individuals to continue to reside at home and receive services through the dementia care program. It may cause certain beneficiaries to delay their election of hospice, but we are going to be considering that as we move forward.
I think on the flip side of that too, we did discuss this quite thoroughly. We think there's a potential that it could actually increase hospice utilization too by introducing the palliative, the care support to that beneficiary. So as they get more complex, hospice might be something more readily accessible and acceptable to the family. So I think it is an area we're going to watch, and I think it's on our list of things to evaluate. I see Lynn nodding her head, so it's definitely an important area. But I think we could see it go either way. It's definitely worth studying.
Yeah, great question and great area for research and evaluation. I think we're at 2 minutes. So I think this will be our last question. The question is that somebody's hearing that large academic health centers are struggling with the RFP requirement to provide contracted respite across their whole service area. What will happen if there's not a robust response to the RFP as a result of that requirement?
I'll take that on. I think this issue has been raised and brought to our attention, and it's something that we are looking at, but don't have an ability to change it at this point. So we will assess if there is an impact as a result of that, but right now do not have a plan to change that. I think we've also, just to call to attention, we've provided opportunities, the requirement that people do contract or provide in-home respite services, and that they can do that through partnerships. So we strongly encourage those partnerships as well. And we've also allowed for the flexibility to provide additional respite services, such as adult day center or an overnight facility for care too. And so really have designed it to be broad and flexible on who can be a partner and who can support the respite services. And we're hopeful that will allow people to think innovatively and creatively of how they can meet that respite requirement. But it is an area that has been brought to our attention. We will continue to monitor
it. So I know we're at 1 o'clock my time. So we'll wrap it up there, but thank you so much to all of our panelists. We're all going to be watching this very eagerly, and hopefully we may be able to invite you back at some time to let us know what you're finding so far and how the model is rolling out. But thank you so much for all of this work and for talking to us today.
Thank you so much for having us today. It was a pleasure. Take care.